Hi, this is Stacy, and I thought I would go ahead and make a video on GI because it was one of my favorite subjects, and I know that a lot of people struggle with it. So I thought I'd just go ahead and make some videos for you guys because I'm on vacation, and I thought, give me something to do. Okay, so since I'm not an official tutor, I do not have like your updated uh, lecture slides. So I'm using my old ones, but I would love if you guys could send me what you have. So I put my email down at the bottom and I will make a new video when you guys send me. I'll show you the ones that I need. I need the the ones from Jones and then the pathology of pancreas and extra hepatic biliary tree. I don't think that was Wang. I messed up. And then radiology of the GI system. That's the only ones that I need. But I will love if you would send that to me if you watch this video. Okay, so we'll get started. So pathology of the intestines 1. So we're going to look at just a little bit of GI microbiology real quick and remember back to first year. So if we look at gastroenteritis, we have either watery non-invasive diarrhea or we have like bloody mucoid invasive diarrhea, or also called dysentery. So watery diarrhea is usually without a fever and they don't have a lot of abdominal pain. It's usually toxin mediated. So we're thinking about like ETEC or cholera. And then we want to look at either is it endotoxin or exotoxin. So endotoxin, it's that LPS part of the gram-negative wall that causes that fever and shock and release of nitrous oxide. Exotoxin are proteins secreted from the bacterial cell that an intoxication inhibits that rapid onset. So they've got that AB components. Let's think of like Staph aureus that's got the heat stable enterotoxin. And then that A is that toxic part. Then we've got cytolysins and then toxoids. Also, other ones to think about are like norovirus or rotavirus. So think of gastroenteritis on a cruise, norovirus, or rotavirus. Think about all of those babies in the and little kids running around in preschool. And then parasitic, and usually this is what happens if somebody has over 30 days of watery diarrhea and immunosuppressed. So bloody diarrhea is usually more severe, and it has with or without dysentery, abdominal pain, and fever. So the only exception here, and it's what I would remember, EHEC does not have a fever, but it is an inflammatory diarrhea caused by a cytotoxin and also C. diff. Inflammatory diarrhea caused by a invasion of intestinal mucosa would be like Campylobacter, Shigella, and Salmonella. Okay. So foodborne illnesses. So we're breaking this down by time of onset. So a rapid short course, 0 to 6 hours, are those preformed toxins. Short are 6 hours to 8 hours. That would be like our Staph aureus or our B. cereus. So remember, B. cereus would be that pre-cooked rice that they left out on the counter all day and they didn't refrigerate it. So make sure you refrigerate your steamed cooked rice or fried rice. So you get an emetic syndrome, which is diarrhea and cramping. Long acting would be 8 to 16 hours, and that's when we get our Clostridium perfringens and more of our B. cereus, which produce heat-labeled toxins after ingestion of contaminated foods. So that's where our like B. cereus is, that we like reheat our cooked rice that wasn't refrigerated, and uh-oh, we still got diarrhea. Longer would be greater than 16 hours. That's when our Campylobacter, Shigella, and Salmonella come into play. So let's look at the different types. Our lactose fermenters, remember that's pink on McConkey's, is going to be our E. coli and Klebsiella, where our non-lactose fermenters, white on McConkey's, is going to be our Shigella and Salmonella. So remember, Salmonella is going to be black and it is motile, where our Shigella is not motile. And so remember our lactose fermenters, we can remember those by like CEEK, which is Clinobacter, Enterobacter, Enterobacter coli, and then Klebsiella. And then the non-lactose fermenters, I think of SHYPS, SHYPS. So our SH would be our non-motile Shigella and Yersinia. And then our motile would be the PS, which is Proteus, and then Salmonella. And I remember the black because salmon swim in black streams. Okay. So E. coli. So we've got ETEC, which is our traveler's diarrhea. It has two enterotoxins, LT and ST. LT is heat labile, ST is heat stable or stabile. And our heat labile stimulates adenylate cyclase. So you've got an increase in CAMP and chlorine outflow, and it results in watery diarrhea. Our heat stable stimulates guanylate cyclase. And so prophylactic antibiotics are usually not recommended. And you would need a second antibiotic in the event of an illness. But our empiric treatment would be our fluoroquinolones like Cipro or levofloxacin or azithromycin. Rifaximin is if it's non-invasive. Our EHIC is enteroinvasive, and that's a watery diarrhea that contains fever, abdominal pain, and excess leukocytes. So if we think back to our little diagram, so our watery is going to be our ETEC, our invasive is going to be our EHIC, and our EHEC. Okay, so EHEC is our 0157H7, non-invasive, no fever, bloody diarrhea in the absence of leukocytes. It is a Shiga-like toxin, which inhibits protein synthesis. This is implicated in hemolytic uremic syndrome, or HUS, and it's transmitted via bovine feces. It's colorless on McConkey's, or on a sorbitol McConkey's, or a SMAC. And this is important to know. So actually, when I worked in the lab, we had a patient that came in. He actually graduated with me from high school, but he worked at a local restaurant in a town nearby. And there was someone that one of the customers returned their hamburger. It was like cut into, and they said, I'm not eating this because there's pink on the inside. So they were going to throw it away, but he's like, well, if they're not going to eat it, it's a perfectly good hamburger. I'm going to eat it for dinner. Needless to say, he ended up with EHEC. And so I got to report it to the state, which was kind of cool. So it came back positive as 0157H7. Here's the problem. So before he came to us, he went to, I worked in a standalone ER, and he went to the actual hospital in our town. And they said, oh, well, you just have diarrhea, whatever. Didn't take a sample or anything. And they gave him antibiotics. So when he came to us, he was pretty sick. He had severe bloody diarrhea. And the issue is, as well, we did a CBC on him and he was pretty anemic. So the antibiotics release toxins and increase the risk of HUS. So he didn't actually have hemolytic uremic syndrome, but he did have pretty bad anemia. So of course, antibiotics were stopped. He got IV fluids and he ended up doing okay. So Vibrio cholera. So cholera reservoir is in the human colon. Usually it happens in natural disasters. And so you think of, I remember like thinking of the slides that they had those like, I don't know, like beds that had a cutout and a bucket under it because there's rice water stools of like 20 liters a day. And it's called rice water stools because it like looks like little grains of rice in water. If not treated, it can result in hypovolemic shock syndrome. So the path of this would be the toxin co-regulated pili, and then we have got cholera enterotoxin, very similar to E. coli LT. And remember, it increases CAMP. So culture stool is on TCBS and it's oxidate positive. So our treatment is going to be fluids and we prefer lactated ringers. It's not good for maintenance therapy because lactate is converted to bicarb and can cause metabolic alkalosis. Campylobacter jejuni is a gram-negative curved rod with a polar flagella. So it kind of looks like gull wings. So it's got that like seagull appearance, and you can see it in the picture. It's oxidase positive, microaerophilic. It grows at about 42 degrees Celsius on a campy or scuro agar. Transmission is fecal oral, primarily from poultry. So I think of like chicken jejuni. I sort of sounds gross, but I think of a like casserole dish with like some chicken casserole dish that somebody brings to like a big potluck, and they're like, oh look, here I bring my like chicken jejuni casserole, and then people get sick. I don't know. That's what I've always thought of when we learn this. It's acid resistant. So people with low gastric acidity are at higher risk, or like lower pH. It can cause inflammatory diarrhea with blood and pus, but here's our important thing to also know. A complication can be Guillain-Barré syndrome. So we have to like think all the way back, oh goodness, to the beginning of the semester and back to like when we learned about Guillain-Barré and back even farther back to micro. And it's got that molecular mimicry of the glycosphingolipids on neural tissues, which causes that rapid tingling and muscle weakness. And so remember, it goes from like toes up, and it can impair breathing and swallowing, and also Campylobacter jejuni can result in reactive arthritis. Shigella. Shigellosis is if you have it. It is a gram-negative rod, non-lactose fermenter, like we said, HUS negative, non-modal, and then it's an anti-O antibody. So that's probably important to know. The reservoir, again, is just human colon. So thinking about like a vignette, like how are they going to ask the question? Think about like daycares, that fecal oral transmission, and it requires a very low infectious dose. So just a few of these Shigella can get you sick. So our path is going to be our endotoxin triggers that inflammation. So it's invasive and it has exotoxin. So it's a double whammy. So we've got blood and leukocytes in the stool. It invades the end cells and polymerizes actin jets. And I sort of remember the actin jets were really important to know. And I would probably, I mean, these are good to know for boards too, just saying, because that's coming. Produces shallow ulcers. And so that toxin inhibits protein synthesis by nicking the 60S ribosomal unit. So our clinical presentation is a pretty high fever of over 101. And then diarrhea starts as watery and then it becomes bloody. So know that it's that double whammy, actin jets, and then also inhibits protein synthesis. Salmonella. I think of Salmonella Ninja Turtles. So they are non-lactose fermenters, mobile H2S producers, cultured on Hectoin agar. And so the path is going to be endotoxin in the cell wall. It invades ileocecal mucosa to the lamina propria, and it increased prostaglandins. We're going to increase the AMP, have loose diarrhea, and shallow ulcers. Patients with that low stomach acidity are also at an increased risk. So think about people that have taken like antacids or they've had a gastrectomy. Sickle cell also predisposes you to salmonella as well. So our empiric treatment is going to be fluoroquinolones, and then if it's invasive, ceftriaxone. Or Rocephin is the brand name. Okay. C. diff. So there's no growth on McConkey's, gram-positive. It's part of our normal flora, but here's our problem. Let's say that you give a patient these broad antibiotics. They come in with like sinusitis, and you give them all this antibiotics, and then they come back and they have all this like diarrhea, and it smells bad. It's terrible. Well, usually following things like giving broad spectrum antibiotics such as Clinda, or like in nursing homes, they have it a lot too. You can wipe out all your good bacteria, and then C. diff comes along and sort of takes over. So it ribosylates GTPases, causing cytoskeletal disruption. So we've got toxin A and B. A damages mucosa, leading to increased fluid and granulocytes, where B is cytotoxic. Remember that it's pseudomembranous colitis. So there's those yellow plaques on colon. So if somebody did a colonoscopy when somebody had like C. diff, this is what it would look like. But that's not what's required for detection. Thank goodness. We've got a better test, well, easier test, cheaper test, and we can check for that toxin. So they have voluminous, foul-smelling, mucoid, green, not really bloody diarrhea. Their leukocytes are going to be like huge, greater than 15,000. I mean, not huge, but like elevated, unlike some of these diarrheas. And complications can be toxic megacolon. So good thing we're not doing a colonoscopy. I guess what happened is like they didn't realize it was C. diff, because since there's all of this like colitis, a colonoscopy can risk perforation. So I would know not to do a colonoscopy. I would know that it has that foul-smelling nastiness, and that it's called pseudomembranous colitis. So our treatment is going to be, and it's like changed over the years, it is oral vanc. If oral vanc does not work, then we go to fixadomycin. We used to say that it should be oral metronidazole, but because it's been given a ton, it doesn't work as well. So oral vanc is our go-to treatment. And that's what I would know. You have to know like what do I do if it doesn't work? Or like, what do I do if I need more later on? That's for third year. But for now, no oral vanc. Something Oh, something like kind of gross, but sort of fun. So also when I worked in the lab, I like had to process like poop specimens. And C. diff is kind of a fun one. If it's like in, let's say, a urine cup or whatever, it can actually like make the cup explode because it's giving off so much gas. So anyways, probably gross. So here's neutrophils erupting from the crypt, looking at C. diff. And then you can also see right here is that pseudomembrane showing those inflammatory cells. And then below it, we've got these congested vessels. So all the neutrophils. So if you see a path slide, this is what it could be. Bacteroides fragilis. It has a low virulence and lives in the intestine. Following abdominal surgery, empiric therapy should cover this. Something else, I guess, to note about C. diff. Sometimes patients will get it after surgery because during surgery, they give patients usually like ANSA and or they'll like give them a good big round of antibiotics, and this can cause them to have they may develop C. diff afterwards. So it's just something to think about in the back of your mind. Norovirus is an RNA virus, non-enveloped, causing that watery diarrhea. Treatment is just to correct fluids and electrolytes. So think of cruise ships. Giardia is reservoirs, animals, goose poop, fecal oral transmission. Think of like food, water, like don't be drinking out of streams, you might get Giardia. It's got the ventral sucking disc attached to the lining of the duodenal wall. They've got that fatty, foul-smelling diarrhea due to that malabsorption. So diagnosis are going to be like cyst or trophozoites, and that's what's in this picture. They sort of have like little faces. And also they sort of like look like falling leaves. Treatment is going to be tinidazole, which is preferred for over 3 years old, or nicotazonide, preferred from years 1 to 3. Amoebiasis is inverted flask-shaped lesions. And transmission is fecal oral. What's scary about this is that it can travel to the liver, lungs, brain, and heart. Vignette usually talks about a traveler from Mexico. And so our clinical presentation is going to have blood and pus in the stool and ding, 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 liver abscesses. So we diagnose this by cyst and trophozoites in the stool, and you can see them right here. Okay, primary spontaneous bacterial peritonitis is going to be empiric coverage covering gram-negative aerobic bacilli and gram-positive cocci. We're going to treat this with third-generation cephalosporins like cefotaxime, and then also broad spectrum like piptazo, or which covers Pseudomonas, or ceftriaxone. Nosocomial infections can include carbapenems like irropenem, celastin, doripenem, or meropenem. Remember always, 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 if you give a broad spectrum antibiotic, make sure that once you get the susceptibility back, that you narrow your spectrum. Okay, and so next we're going to talk about inflammatory bowel disease from pathology 2 and then farm of GI motility.